Good morning, everyone, and welcome you for the second day of the 2025 International Conference on Drug Policy, YABA, Methamphetamine, and Synthetic Drugs. And today, for this morning session, you have me, Thanaphum, as your MC. And for the schedule throughout the day, we will have two important activities in the morning. The first one is a keynote address under the topic of appropriate outcome for medication-assisted treatment of stimulant use disorder by Professor Dr. Michael Farrell from the National Drug and Alcohol Research Centre, University of New South Wales, Australia. And after the keynote address end, we will follow with a session of the second plenary session under the topic of the scale-up national and international initiatives to enhance effective services for people with stimulant use disorders through research and practice. And after the plenary session end, we will have a morning coffee break. Let's say between 10:40 to 11. And after that, we will have a breakout room session in the morning starting from 11. And in this case, please make sure that the presenter of each breakout room, please make sure that you proceed to the room prior to the presentation time, maybe 10 minutes, as to upload your file successfully with a computer. And after that, we will have a lunch break at the market on the 5th floor, and then we will start with the afternoon session in the breakout room from 1:15 and 1:15, and after that we will have a afternoon break, maybe let's say about 3 p.m. And okay, let's start the day with the first one. We will start with the keynote address by Professor Michael Farrell. And before this, let me give just some short bio of the Professor Farrell to you. Professor Michael Farrell is a Director of National Drug and Alcohol Research at University of New South Wales, Sydney, Australia. And he is a psychiatrist with a background in clinical area, research and policy. He previously led the National Addiction Centre at King's College, London, before relocating to Sydney in 2011. He has played a key role in shaping drug and alcohol policy in Australia and internationally. He led the review of medicinal cannabinoids for the Therapeutic Goods Authority and contributed to clinical guidance and federal opioid treatment guidelines. He co-developed the treatment outcome profile and led the International Consortium on Health Outcome Measures on Drugs and Alcohol. And also, he was a chair of the Australian National Advisory Council on Alcohol and Other Drugs, and a long-standing member of WHO Expert Committee on Drug Dependence. He contributes to media and public policy discussion on addiction and drugs reform. So, ladies and gentlemen, please give a warm welcome to Professor Dr. Michael Farrell for the keynote address from under the topic of appropriate outcome for medication-assisted treatment of stimulant use disorder.
Thank you very much. Thank you very much. Apologies for that extended biography. Look, I'd like to thank the organisers profoundly for this opportunity to engage in this very important conference on a very important topic. And my title is, I've been asked to discuss appropriate outcomes on medication-assisted treatment of stimulant use disorder, and I'll be talking about work that not just I have done, but many of my colleagues, including John Marsden here and Nadine Ezard and different people. And it is great when we work together in a collaborative fashion. And I'm very clear that one of the purposes of this meeting is to enhance our international collaboration and our capacity to support each other in researching this very important topic. I'll go through a range of broad issues about the treatment landscape, pharmacotherapy and evidence, and some outcome measures and conclusions, and try to put it in some broader landscape. Before I do that, though, Anya, who sent me this last night, which reminded me that this is a thing from the Neuroscience of Psychoactive Substance Use in 2004, in which I wrote with John Marsden, Robert Ayla, and Walter Ling. And it reads, in the short present situation, warrants immediate attention with a major epidemic of methamphetamine use in Thailand that appears to be spreading across the entire Asia-Pacific region. Researchers have stressed an urgent need to map out this epidemic, to assess the spread and scale of the problems, consequences, and responses. And that was written in 2002 after we, on a WHO project in Chiang Mai with Appenin in 2001, where we observed the impact on young men on YABA-induced psychosis. And it was actually quite a profound moment for seeing just how big this problem was developing and what huge impact it was having on the community. Now, I think one of the issues in this is not just that shows you that I'm getting old and it's 25 years ago, but that actually it's interesting that the problem is not that dissimilar now in relation to developing responses. And I think one of the things when we talk about investment in research and development around alcohol and other drugs, if we compare it to cardiovascular disease or cancer, the lack of investment and the lack of commitment to developing good responses. And one of the examples, I think, if we look at, it's not exactly comparable, but if we look at what happened around the COVID vaccine and how quickly, when the public health exigency existed, how quickly we came up with a vaccine. What we do need is we need major international commitment to better investment in developing structured responses to these problems. And we haven't had enough of it, is the thing. And if we look at it, one of the big challenges for us has been, yes, we have some psychosocial treatments, but we don't have any medication at the moment for any government-approved medication for the treatment of methamphetamine. And it leaves workers in the field exposed, not having the supports and tools available to enhance and achieve the maximum impact, and particularly strategies to boost both retention and reduce relapse in addiction. So that being said, to this audience, I don't need to convince you of the scale of the problem, and that our estimate, this is from a series in The Lancet, and if anybody wants a copy of it, they're welcome to email me and I'll send them a PDF of it. But we think about 11% of people exposed to methamphetamine become dependent. And the other thing is that the mortality rates in the Australasian region, or the Asia-Pacific region, are the highest in the world. So that shows you the concentration of the problem in the region and the importance in the region of cooperation to tackle it. And this shows you that the range of things, unlike opiates where we would talk primarily about accidental deaths, etc., we have a range of causes, which is suicide, poisonings, accidents, cardiovascular, homicide. So a whole range of causes of mortality, a more complex problem in many ways than the opiate problem. And this is just something. But on top of that, we don't just have methamphetamine. We have methamphetamine mixed in with a range of other substances. And we must factor that into how we respond to things, that the polydrug use is a global issue, and when we just talk about one substance without considering the other ones, we really can lose track a bit. If we look at non-fatal harms, we've got intoxication and dependence, but importantly, depression, psychosis, and violence are areas for moderation and influence, and physical health and cardiovascular risk, as we've mentioned. And this just shows the same thing. And here we have the thing in relation to amphetamine use and its impact on psychosis. And this is a review, and you can see that virtually every study shows a 2 to 4-fold increase of risk of psychosis in related to exposure to amphetamines. So then we move from looking at the scale of the problem and the range of the problem to the treatment landscape. And we know that never mind the coverage of the treatment, but the access and utilization of services is way below what is needed to affect an adequate public health response. So we've got both the investment into treatment responses, but also looking at the strategies of how do we attract users into treatment, and how do we make treatment attractive enough, and also how do we have incentives to bring people into treatment, but also how do we develop strategies to divert people from the criminal justice system into the treatment system. And if we even get them in, then how do we retain people? And in that context, I think we have not paid enough of attention to strategies to both reduce psychosis and suicide in this vulnerable population. And then, so how do we reduce harms with both psychosis and suicide, but also reduction in mortality? And then on top of that, what are our strategies to manage withdrawal, effective management of withdrawal, managing maintenance medication, and managing abstinence? So one of the questions, it's traditional often for people in the broader field to have the view that addictions treatment does not work. That was historically the view, and one of the missions we have is to get clearly across to people that that is not the case, that people have remarkable benefits from treatment, but some of the treatments as we stand them are undifferentiated. So it's, while we can see people significantly benefit from the treatment, but we can't see that one particular type of treatment is substantially better than the other. And the only exception to that seems to be contingency management, and that is where there's reinforcing strategies for desirable behavior. But that has been very hard to actually implement. It's been possible to show research-wise, but it's been very hard to implement at a policy or at a routine level. In actual fact, it's one of the few pieces of evidence-based treatment where we have evidence for the treatment, but very little capacity to deliver the evidence into the ordinary sphere. And this just shows what I've been talking about there, that it's not that these things don't work, but they're undifferentiated in their impact. Counseling, CBT, community, interpersonal therapy, self-help interventions, motivational. They all deliver an impact, but we would prefer to have a much stronger impact. And in the future, we would hope that some of these things, in combination with newly developed medication therapy, may have a combination of effects to improve outcomes. And probably the only other thing to say in this is we're also clear that the evidence for compulsory drug treatment is very poor, and that actually it has likely no effect. And we've been quite keen to get this message across. It doesn't seem to get across very well, but it is a lot of resource that's expended that could be more effectively expended through community delivery systems, contingency management or other types of potentially coercive strategies, but coercion and diversion into treatment rather than removing people from their communities. Drug court and police diversion is quite a different thing. There's interest in it, they're a bit expensive, evidence is weak, but there's in the context of methamphetamine, there's a good case for them. And this is an example from New South Wales of the magistrate's early referral into treatment over the last few years. This is 11,000 people with methamphetamine dependence who are referred from the court to treatment. And if they complete the treatment, what you see is that those who complete the treatment, which is 69% of them, are nearly 3 times less likely to go back to prison. So that's actually, now this is a selection effect and we need to be careful because it's just routine outcome, but still it shows that there is a value to this thing and that positive outcomes can be delivered. If we then look at the territory of pharmacotherapy evidence, and I have to say that the National Institute of Health and National Institute of Drug Abuse have been one of the world's biggest investors in efforts to find treatments. In actual fact, they've not been very well supported by other countries around the world in this, and I think we owe them gratitude. Unfortunately, their investment hasn't been fantastically rewarded in relation to progress. But this is a slide I got off Steve Shoptaw, and it really asks if there was an effective pharmacotherapy for stimulant use disorders, what would it do? Well, what kind of medication would it be? Well, it could either be a full agonist, a full antagonist, a medication that affects mood, cognitive enhancer, something to remodulate cognitions, or possibly monoclonal antibodies or chelators for intoxication. And what would these medications do? Well, the first one would substitute a stimulant effect, as in lisdexamfetamine or something. The second would block a stimulant effect. The third would relieve withdrawal, craving, and symptoms. Fourth would improve cognitions. And the fifth would reverse intoxication or overdose. So that's the menu of things that are potentially possible. And if we look at it in terms of the interventions we have and the reviews of these, we see there's a little signal for psychostimulants. The studies are good, but the effect is quite weak, but it is signal there that's worth paying attention to. There's been a number of studies on naltrexone and a number of studies on some other medication, mirtazapine, lisdexamfetamine, and combination approaches. Nothing definitive, but if we look at it, after 25 years, there are some signals, but there's no approved treatment. The mirtazapine work done by Phil Coffin in San Francisco with MSN has been pretty interesting and has been replicated by us in Sydney, and we will be publishing that soon. There's been some very interest in naltrexone, bupropion. There's a positive study there, and there's need for replication in that. There's the signal for dexamphetamine, and recent work by Nadine Ezard and colleagues on lisdexamfetamine indicates the need for further research on use in both maintenance and withdrawal management. So the summary of that really is that there's evidence to consider medication as a foundation of treatment for stimulant use disorder into the future and how we move with that. Then the question is, well, what sort of outcomes do we use? And I chaired this thing which was called the International Consortium on Health Outcare Monitoring, and Sweettree was on the group, as was Appenin. And I think the document that was developed, there's now a Thai version of it. I don't know that it has been used clinically. The idea behind it was to pull together the data and look. Let's be clear, there is no prescription, there is no ideal way to measure these things, and there's nobody laying down the law on what should be done. There's a need for flexibility. At the same time, we need to look at the issue of, this was a group that looked at the literature, looked at lived experience and fed back, and then came up with a very simple framework. You've two basic areas. You have symptom severity, which is symptom burden, frequency and quantity of activity. And that's basically what we look at most of the time. And then down the other side, we have function and well-being, which is quality of life, global functioning, psychosocial functioning, health, physical and mental health. If we look at the instruments available, and I'm sorry, I'm not mentioning them all, and if somebody's instrument isn't mentioned, my apologies. But we have, first of all, Robert Eli and the WHO assist for screening and brief intervention to pick up problems. And then we have the treatment outcome profile that was developed by John Marsden with some minor assistance from me, and is used in the UK system across the whole treatment. And this was modified by Nick Linzeris for Australian treatment outcome profile. You've got the addiction severity index from Tom McClellan, and you've got some patient-reported outcome measures. Now, the significance of these are mainly used for standard treatment measures rather than for research purposes. And some of the discussions about outcomes are, what are the measures we need to monitor how we're delivering treatment across the board, and then what are the sorts of measures we might need for specific research purposes. And I think one of the problems with all of these measures has been the burden they've imposed on clinical services in collecting data. And the question is whether some of the new AI strategies and that might enable us to have more efficient ways to gather information in the clinical arena in a more structured way, but that's all for the future. We then enter the issue of clinically meaningful outcomes, because one of the things is to have a change, but then how do we decide if this is significant? And there's a lot of difference of opinion about this, about, for instance, in smoking, we have a measure which is what percentage of the population are abstinent at 6 months, having successfully quit it. But we go from that to sustained abstinence, to reduction in use, and to mental health symptom improvement. I think we will be discussing this for the next 5 years, but it is the question of the translation between what's a measurable change and what's a meaningful change. And this is a slide Nadine gave me from Krista Seafried, and it looks at a review of 43 clinical trials, which shows that of the 43 trials, they had 55 different primary outcome measures. So that tells its own story. The three main outcomes are abstinence, craving, and change, use, reduction in use. But again, you see the diversity. And one of the challenges in this, if we have such diversity, how do we end up getting data that we can pool and meta-analyze? And this was the thing from the iChum thing, where in the different instruments used, there was 73 possible different outcomes in that. So then if we look at it in terms of functional outcomes into the future, where we're going, we've got substance use, mood and mental health, cognition, occupational morbidity and mortality. And this is back to what I was talking about earlier. It is pretty clear we've got a mixture between self-report versus biological testing. We've recently done an extensive review of self-report versus biological measures. And both from the point of view of most purposes, particularly when it comes to conventional treatment assessment, the self-report meets the same criteria as biological once there isn't some contingency. If there's a contingency around self-report, it will modify the self-report in a way that then significantly distorts the finding. But overall, we'll be looking at use, days, amount, abstinence, and relapse and withdrawal. And then within mood and mental health, I think sleep is one of the important areas for us to pay attention to in terms of outcomes, but mood, psychosis, suicidality are all very important measures. And then in terms of quality of life, EQ5D, WHO, and then injuries. And then the other one that needs work is neonatal outcomes. So, in conclusion, despite decades of problems, we're still lacking evidence for effective drug treatment for methamphetamine problems. However, pilot studies and other smaller studies show promise. There's a critical need for international cooperation to develop a platform of rigorous studies, develop new and effective treatments if we're fully to tackle this major problem. There's a need for agreed and consistent outcome measures to enable robust comparative analysis. And I hope that we will, in this meeting, contribute to that process. Thank you very much.
On behalf of the organizing committee, I would like to give a sincere thank you for Professor Dr. Michael William for giving his very useful insight for for his experiences. And then for the next one, we will have the plenary session by 5 panelists under the title of Appropriate Outcome for Medication Assisted Treatment of Stimulant Use Disorder. So, maybe let's have some few minutes for preparing the table for the panel sessions. So, ladies and gentlemen, please give the warm welcome for the panelists, starting from the first one. Professor Dr. Nadine Ezat of National Drug and Alcohol Research Center, Faculty of Medicine, University of New South Wales, Australia. And for the second one, Professor Dr. John Marsden of Institute of Psychiatry and Psychology and Neuroscience of King's College, London, United Kingdom. And the third one, Professor Dr. Suwarna Arunpong Paisan of Thanyara Khongan Hospital, Thailand. And for the next one, Ms. Anya Bose, and from WHO headquarters. And the last one, as the moderator, is the Dr. Alireza Nuruzi of Afghanistan WHO country office. In this case, I would like to give some short bio about Dr. Nuruzi. He has some background into the field of mental health and substance use disorders, especially in the treatment and harm reduction of substance use disorders and addictive behaviors. And Dr. Nuruzi also involved in clinical research and both pharmacotherapies and behavioral interventions in addiction medicine. And his current work addresses the treatment of the methamphetamine use disorder, treatment of opioid and cannabis use disorders among children and adolescents. Please, may I invite the panelists to the stage, please.
Good morning. It's a great pleasure and honor for me to moderate in this panel on a scale-up national and international initiative to enhance effective services for people with stimulants use disorder through research and practice. The first speaker will be Professor Nadine Azard. She's an addiction medicine specialist and a founding fellow of the addiction chapter in Australia. She has an extensive background on research, development of the RCTs for treatment of stimulant use disorder in Australia, and she has pioneered treatment models for stimulants and polysubstance use, integrating trauma-informed care, harm reduction, and person-centered approach. So the floor is yours, and please, thank you.
Thank you very much, Dr. Ali Reza. And thank you to the organisers for inviting me here. I'm very honoured to be here today. I'll just start by acknowledging that I work for St Vincent's Hospital in Sydney and also the University of New South Wales, and I have no commercial conflicts to declare, which is important. I'm talking today about in the context of Scale Up, which is our global informal initiative supported by UNODC and WHO and the European Union to try to come together to develop new and effective treatments for methamphetamine use disorder and to scale them up to actually have a population impact. So I'm just presenting some of my perspectives from Australia in this discussion. Just as a reminder, this is the pyramid that shapes our current treatment frameworks. So the majority of people who use methamphetamine or YABA will have a mild disorder and can usually be managed themselves through self-care and informal community care by family and other community networks. As the increase in the severity of disorder grows, we need to provide healthcare through primary health services and general social welfare services. For those with more severe disorder, we consider the need for specialised treatments. And at the top of the pyramids, a lot of countries consider that long stay residential service is the only treatment available. This is the population that we really have very little treatment for at the moment. Professor Farrell already outlined some of the evidence on what is available, but this is where we need to be doing our work. We can map that treatment pyramid onto various diagnostic frameworks. So we use often the International Classification of Diseases or the Diagnostic and Statistical Manual. We call it either dependence or severe use disorder, and that's the top of the pyramid that we are very much concerned with. And that's the area of current research which we are looking into. And from the Australian perspective, Professor Farrell went through some of the current evidence and also some of the research evidence that is being built at the moment. We've just completed a trial of lisdexamphetamine for methamphetamine dependence. We also are in the process of running a trial of lisdexamphetamine for methamphetamine withdrawal, a multi-centre randomised control trial, and we've just started with that one. Naltrexone bupropion, Professor Farrell also mentioned the evidence for that, and I'll go through some adaptation that we are looking at in Australia. And metazapine, we're hoping that the results will be published very soon from the Australian multi-centre study of that. Telehealth delivery options are also of interest because this is a way we can reach more people than we are currently reaching through clinic-based care. And I was very pleased on Monday to be taken on a visit to services here in Bangkok, and telehealth is already being implemented here as well. So this is an interesting way of delivering the services going forward. The psychosocial interventions, Professor Farrell mentioned contingency management. We are yet to explore how that might actually be implemented in practice. Internet-based CBT, we had a very interesting talk from our colleague from Korea yesterday who is also working on this. We are working on this in Australia as well. And then we do have already out now an app for self-administered monitoring of methamphetamine use and promoting people to seek treatment if they might need it, because we know one of the biggest barriers to receiving care for methamphetamine use disorder is a lack of recognition that treatment might be helpful for the person who may be running into problems with their methamphetamine use. So the first pharmacotherapy that I would like to mention is the combination of bupropion and naltrexone. Professor Farrell mentioned this. The bupropion is actually already on the WHO essential medicines list as an atypical antidepressant, and it's approved in many countries for depression and in Australia and on the WHO list for smoking cessation. Naltrexone people will be familiar with as an opioid receptor antagonist. It's also on the WHO essential medicines list for alcohol use disorder, and in some countries it's also used for opioid use disorder. The study that Professor Farrell mentioned from the US used a combination of a long-acting injectable formulation of naltrexone. This is very expensive in most parts of the world, in the thousands of dollars. It also used a long-acting extended oral preparation of bupropion, which also is not available in many countries. The evidence is sufficient that recent US guidelines recommended, especially if there was coexisting alcohol use disorder or depression or nicotine dependence, so any of those other indications for which those medicines are already approved, to consider using this combination already. Unfortunately, those two drugs are not available in most countries, but the generic bupropion tablet and the generic naltrexone tablet is and reasonably cheap. In Australia, we also have a combination of those two medications as a diet pill, and that's also much cheaper than the combination that was studied in the US. So we have completed a pilot to see if it's feasible to use that combination to see if it's safe, and we do believe it is. So the future for that, I think, is exploration of these more affordable formulations of the medication. The other study that we think is somewhat promising, although I would agree with Professor Farrell that the outcome is mild, this is not going to be a miracle cure, but it does certainly seem to help some people reduce their methamphetamine use over a period of time. We conducted a randomised control trial of 155 people. There was only weak evidence of the primary outcome, which is reduced use in the last 4 weeks of treatment over a 12-week treatment period. But there were 9 fewer days over the 12 weeks in the group receiving the active medication. That's lisdexamphetamine. Lisdexamphetamine is a prodrug of dexamphetamine. It's metabolised into dexamphetamine in the red cells. I feel it's the effect of the medication is very similar to dexamphetamine, which is available widely in many countries, not this country, but in many other countries, and it's very inexpensive. It's an off-label, it's an off-patent medication. This dexamphetamine is also encouragingly off-patent in many countries, not in my country, but in many other countries. So the cost of that should come down. In our study, we offered 4 sessions structured cognitive behavioural therapy. Most people did not engage in therapy. Most people only had about an average of 1 counselling session in both of the groups. So the medication works through a medication effect, if it's going to work, not through the engagement in counselling. These results are somewhat consistent with the recent US guidelines that suggest consideration of stimulant therapy by specialist clinicians with close monitoring. And I think our results at least suggest that if there's no improvement in the first 8 weeks, and when I say improvement, I mean the primary outcome was reduction in numbers of days used over the previous 28, then probably this medication is not going to work for people. This group of people that we studied, they were using very, very frequently. They had to be using at least every more than 14 out of 28 days at baseline, and most people were using 20, 24 days at baseline. The other thing that we've already mentioned today is contingency management. This is very strongly recommended in the US guidelines. The evidence is strongest from settings in the United States where there are 3 times a week supervised urine drug screens. This is not feasible in many countries and not acceptable for many consumers and clinicians who on studies have been concerned about equity and alignment with client-directed treatment goals. However, I do feel like we have there is potentially a place. The question is what is being rewarded. So for something like opioid treatment, you can actually provide contingency for engaging in methadone or buprenorphine or one of the opioid agonists because we know those medications have evidence of effect. So the question for us when we're looking for treatments for methamphetamine use disorder is what is it that we would like to reward other than negative urines? And there's some work to be done, I think, along the role of contingency management alongside some of the other therapies. I mentioned already telehealth. I think that we've recently completed a study looking at the effectiveness of telemedicine to enhance uptake and of addiction medicine services, primarily again for opioid agonist therapy, which we know has an evidence of effectiveness. There's certainly a role, I think, in methamphetamine use disorder, but without a medication treatment, the actual role is not so clear for me just yet. The internet-based cognitive behavioural therapy we've mentioned and the self-administered motivational app we've also mentioned. These are very low cost and can be provided to people at various stages in their treatment journey and also potentially while they're waiting for treatment if we are delivering treatment that is the demand exceeds the supply of the treatment. Oops, sorry. So in conclusion, there are a number of promising options for scaling up, and I think we should be looking at combinations of medications, but also combinations of contingency management plus the medication. There's a role for telehealth and waitlist self-administered interventions. We do need the cost-effectiveness data for scale-up, and the next step is multi-country studies, and I'm really hoping that that's something that we can get out of this meeting here this week. This is the scale-up program that Anya Busse, I'm sure, will mention at the end. And that's my email if anyone has any questions or would like to reach out to me. Thank you very much.
Thank you very much, Professor Nadine, for your excellent presentation. We have time for if the audience have a question from Professor Azar. I use this opportunity and ask a question regarding this internet-based CBT. I want to know your opinion. Do you think it we know that we are living in an era that day by day new technologies are introducing. Do you think it can be a treatment alone, or it will helpful as an adjunct to the current and clinic-based services?
That's a very good question, and I think there are two things for me with the cognitive behavioural therapy. We don't know if it's going to be effective as a self-administered intervention. And we've already seen from the data that Professor Farrell presented that that cognitive behavioural therapy itself has very limited effectiveness, and probably for people who are not using so frequently, maybe less than 14 days out of the previous 28. Where I do see the real value with internet-based CBT is that it can help practitioners who may not have a lot of training or experience in delivering this. It can help them also standardise their cognitive behavioural therapy, and that can be done as a clinician-assisted therapy as well as a standalone one. Both of those things have not been studied, so we don't know. But the other point that I'd like to make is that with the coming era of AI, already you can go in now and type in, please give me a cognitive behavioural therapy program for methamphetamine use disorder to any AI program, and it will give you quite a reasonable response. So the more that we can feed in good quality cognitive behavioural therapy that's internet-based into the internet system, the more those large language models can actually extract better quality cognitive behavioural therapy. And I think that's the future, that we need to be looking at how we can adapt and use AI and the existing evidence-based cognitive behavioural therapy. So I think that will be a low-cost, reasonably widely available treatment for people at the bottom end of the pyramid. At the top end of the period, the internet-based CBT might be able to be delivered alongside some of the treatments that might be available for more severe disorder.
Thank you very much for your valuable input. The next speaker is Professor John Marsden. He's professor of addiction psychology and in Institute of Psychiatry, Psychology and Neuroscience in King's College London. Professor Marsden is a practitioner and clinical research psychologist, and he's head of addiction department at the Institute of Psychiatry, Psychology and Neuroscience, King's College London. He's the senior scientific advisor for the Division of Drugs and Alcohol Prevention, Evidence and Delivery, Department of Health and Social Care, and a clinical academic consultant for the U.S. National Institute on Drug Abuse. A clinic for clinical trial network, John's research, Professor Marsden research focuses experimental therapeutics in opioid stimulants and alcohol use disorder, with recent grant support from the National Institute of Health Research, Endeavor, Beckley Psychtech. He is editor-in-chief for the scientific journal Addiction, the prestigious journal in addiction medicine. The floor is yours. Thank you.
Dr. Nawrouzi, thank you very much indeed. I'd also like to extend my gratitude and honour to the organisers for the kind invitation to join an absolutely incredible meeting. There seems to be strands of opportunity that have come together. The very welcome resolution with the Kingdom's leadership, with Norway, and of course the long-standing work of the NCB here and the clinical networks in Thailand across the Kingdom. And in the sense that today and tomorrow we continue to look forward with this leadership event to take the resolution into action, I'm going to present something that I generally don't do, which is to tell you about a plan that we're going to implement. Most of us hide for a long time while we're working on our trials, crossing our fingers, holding our breath that we'll be able to pull them off. But I hope that the plan that I'll set out resonates with the planned clinical trials that are being configured in the kingdom. And I'd very much like to echo Nadine and Michael's call for collaboration and partnership. This is a global problem, and learning from one another is sewn into my DNA, as I'm sure it is for everyone around the room. So I'm going to talk about a randomized controlled trial for people with moderate to severe stimulant use disorder. And I'm going to talk about a trial that's going to study the individual and combined effects of lisdexamfetamine and metazapine. So these are two medications that you've already heard a lot about this morning. I'm going to, as you'd expect, locate the presentation in the context for the United Kingdom. And there are going to be some, in a way, headline differences that I hope you'll allow me to outline, but they are instrumental in shaping the rationale and the specifics of this particular trial. So you've heard, I think, some of my affiliations. I have some disclosures that relate to pharmaceutical industry funding for recent trials, and one in particular that we're about to launch, which is in a different space, but I think chimes as well with the interesting discussions I heard yesterday about recovery support functions, and we're doing a study of recovery check-in for AUD and other substance use disorders. But I extend my gratitude to the National Institute for Health Research, our evidence for mechanism and efficacy program for funding the trial I'll talk about this morning. This just sets out a little bit of the background and why we're so excited about the opportunity to study medications for cocaine use disorder. My clinical group in London have been working to deliver trials in the opioid use disorder space in the last 10 years or so. Also alcohol. We've got a study, stage 1 application using oral ketamine for AUD with, as an assistant for CBT. And our cocaine work has lagged behind terribly for us. It's been very difficult to get funding. We're very much an investigator-initiated effort to receive funding. In the UK, there is methamphetamine, but it's very localized and quite small scale. And the predominant stimulant that we face in the UK is cocaine. So we've done some development work on CBT and particularly mental imagery. So our trial is going to be the first RCT for cocaine that's ever been conducted in the UK, which is really shocking, really. But it's timely and I hope, as I say, synergizes with the work that's being conducted in Australia and to be conducted in the Kingdom. Just to make a couple of quick points about cocaine and methamphetamine, if we just go for the smokable form of cocaine and the crystalline formulation of methamphetamine, so crack and ice, in a way, crack, the smokable alkaloid formulation or form of cocaine, is a short-acting ice. They both reach the brain at about the same time. Crack has a much, much lower melting point. It has very, very short subjective effects. And what that does in sort of phenomenological context is the individual receives a very rapid plummeting dose of the drug, which initiates redosing. And so there can be very intense consumption, redosing after several minutes sometimes, over an episode of intense use that can vary from a small number of hours to possibly a couple of days, after which there's usually a period of, shall we say, calm before the drug is taken again. And that is different most of the time to methamphetamine. But if we think of crack as a short-acting version of ice, we're really talking about the same neuropharmacological function, and cocaine's just an uptake blocker. So about 23 million people use cocaine around the world. About 1 in 16 develop dependence in the first year of trying the drug. There are chronic adaptations in the usual areas of the brain that are implicated in addiction, particularly dysfunction in areas that relate to memory and planning and craving. It develops through a worsening cycle of exposure. Craving, negative affect, and withdrawal symptoms are the primary motives for continued use. We tend in our research studies to use the DSM-5 framework, as Nadine has mentioned. And so in our studies, we're looking at really involving people who endorse about 4 to 6 or more symptoms of the 11 symptoms of DSM-5. So these are moderate to severe patients. As Michael was saying at several points in his keynote, we're really talking about multi-component problems in all of our substance use disorders, but particularly the stimulant use disorder arena. Chronic sleep disruption. So about 80% of patients with cocaine have really disrupted sleep architecture. We've got high levels of depression and anxiety. Cognitive impairments are high, and especially this comorbidity with ADHD. And these problems are complex. They can be consequences. So if you like, cocaine can be causal. They can be background factors in which there are other causes, but together they make cocaine use disorder harder to treat. In England, there's a really pressing need for this trial that we're embarking upon. We've got about 116,000 or so people that attended services last year with powder or crack cocaine use disorder. And very few of them were offered anything helpful, and most of them didn't stay for very long. The punchline here, though, is that about 50% of this population have comorbid opioid use disorder. Now, that recognition instantly helps you think about the type of candidate pharmacotherapies that are going to be appropriate for a group of people, many of whom are going to be seeking opioid or partial opioid agonist pharmacotherapy. So that rules out naltrexone, for example, and several other candidates. Cocaine-related harm in the UK is really going up. Last year, we had over 1,000 people die of cocaine toxicity, mainly cardiovascular, and that's a 30% increase. So, as Steve Shopto wisely wrote, and Michael alluded to this morning, what we need from a maintenance pharmacotherapy, if we're just looking specifically at a therapeutic agent, then it's got to really relieve craving and withdrawal symptoms. It ought to block any lapses to non-medical stimulant use, so the reinforcing effects. It must have acceptable safety. I throw in ideally simple dosing. Unfortunately, as Michael said, many of the candidates failed against placebo. Our open label trials are generally good signal progression studies, but when you bring in a placebo, everything falls apart often. So our hypothesis is that cocaine use disorder is of sufficient complexity that we need a combination approach to map to the symptom profile. So we think no single candidate would be able to cover the range of symptoms. And one might hope for a synergy of effects when the two medications that I've mentioned are added together. So Nadine's wonderful study published this year gives us hope that this agent can attenuate craving, boost cognition, ameliorate fatigue, block reinforcing effects, but also activate people in the way that it does with ADHD to recovery-oriented activities. And metazapine brings in, obviously, as an atypical antidepressant, some welcome effects on reduced craving, Phil Coffin's work has showed, and also improved mood, and at certain doses, perhaps improvement in sleep quality. And we're going to be testing these effects clinically, but also in terms of neurological changes. So the study design is a 2x2 factorial. So what that means is that patients are randomized, participants are randomized to get 2 tablets, one taken in the morning, which is when you take lisdexamfetamine, and one at night, which is when you would take metazapine. But no one knows what the tablets contain. So equally, we're going to randomize people to get active doses of both drugs, active doses of one drug and the placebo of the other, and 2 placebos. So that's the 2 by 2 factorial. We're using the label for lisdexamfetamine. There's probably a lot of detail we could get into about the doses required for methamphetamine and cocaine, but at the moment we're looking at scaling up over 3 weeks from 20 to 80 milligrams, titrated on effect, safety, and willingness to increase. So that allows placebo people to increase their dose, if you will. And we're also, with metazapine, rising up to 45 milligrams if people wish to, at which point it should be less sleepy, but some people may want the drug effect to induce sleepiness. So we've got that flexibility. And we're going to randomize 400 people. 3 weeks of titration, 12 of maintenance or stable dosing, and 3 of taper. So it's an 18-week treatment with then a 6-week follow-on. So with phase 2b studies, you don't want to have a really long follow-up period because you're beginning to study other things. But that 6 weeks gives us our primary endpoint. I mentioned fMRI. I'll hopefully have time to cover that very briefly. We're going to be looking at quite a lot of heavy lifting from statistics on moderation and mediation. And our secondary outcome measures align completely with Professor Farrell's vision. The setting for this will be 8 National Health Service specialist addiction clinics in England and Scotland. The inclusion criteria, I think, are unremarkable, so I'll skip beyond that. But it's a current dose of cocaine, at least 12 using days in the last month, documented positive urine drug screen. We're allowing patients, if they can adhere, some take-home medication. We're yet to get that past our Medicines and Healthcare Regulatory Authority, but we believe that's a flexible patient-facing approach, but we'll see if we can achieve that. I don't want people to have to come in to pick up their medication every day, that's for certain. We're going to be excluding people, as you can see, with receipt of other medications in the same space, and certainly through medical screening for cardiorespiratory disease and so forth. The primary outcome measure, we like counting days. That's what we do in my group. All our studies have the same outcome measure. So we're going to be counting cocaine abstinent days through timeline follow-back with urine drug screen on each visit. With urine drug screen trumping self-report, if you will. And that gives us an outcome measure that ranges from 0 to 168 days. We like also visualizing the profile, the patient-level profile of that. And this is a heat map, for example. This was an extended-release buprenorphine trial, but with 50% cocaine users. And this is the cocaine-using profile among people that got the injectable buprenorphine. So it's 87 people. And you can see it's ranked by response. So the green is a day of abstinence. The red is a day of cocaine use. The gray bit, the bite at the bottom is treatment retention, or rather the exit. You can see that there's some response, and there's a big sort of red waistband in the middle of non-response, but good retention. So people in our trials do tend to stay, but cocaine is a real resistant. It's like a bully. It just wants to stay. It wants the person to keep on using. Our powered study sample is 90% for overall for our trial. So we feel we're able to manage what is a very challenging 2x2 factorial design. Finally, we're going to be doing some analyses which I think are quite exciting. This is a directed acyclical graph for MEDCO, the trial. So we're going to be looking at the primary outcome, as you'd expect, for the 4 groups, the overall in each group. We're going to be looking at mediators. Our putative mediators are craving, sleep, cognition, ADHD symptoms, we're stratifying for that, and anxiety and mood. So we think that if there's an outcome effect, the drugs clinically are acting upon these clinical symptoms, and changes in those symptoms are the causal factor that relates to change. We've got some treatment modifications. So these are things that existed before randomization, but change the way the treatment is delivered. So they causally act on treatment, even though they weren't randomized. So things like the type of CUD. I forgot to mention we'll open this trial to people with powder cocaine as well. Obviously, people who may or may not be on opioid medication. We'll measure severity as well. So those modify in a causal diagram. We're going to be covering colliders. A collider is something which has got two types of cause. So it's got two causal pathways to it. We won't have that in the model if there is any evidence for collision. And then we'll measure unmeasured confounding, if that doesn't sound like a tongue twister. So this is the size of a factor that would need to be of a certain size to overcome the findings of the trial. The other thing we're going to be doing is use an fMRI setup so that we will expose patients before randomization and at the end of the trial to a series of Q exposures. This is a set of cocaine paraphernalia that a patient brought into our previous study. So patients will be able to select material that for them idiosyncratically is associated with craving. So for example, objects, we'll have real objects, not just pictures. We show people a video. We produced a video of people preparing to smoke cocaine. Had a profound effect on heart rate, variability, stress and craving, as you'd expect. And we put that together as a provocation, if you will. This is all on a voluntary basis. We have a talk down so patients are able to leave the clinical setting not harmed. But we'll be seeing if that has an effect before and afterwards, and using fMRI to determine if there are changes in the structures I mentioned that are associated with both medications or one or other. So in summary, Medco will be the first ISCT to investigate the combination of LDX and MZP for stimulant use disorder, certainly the first for cocaine use disorder. It's going to be offered to adults in England and Scotland who are using powder or crack cocaine. They may also be concurrently dependent on opioid use disorder. 18 weeks of treatment, as I mentioned. We include analyses of clinical mediation and Q reactivity. It won't be the end of the story. If we get the progression-informing findings from this phase 2b, then we go to phase 3. And in phase 3, it will probably be larger. It may be both. It may just be one of these drugs, or we may exit. But we'll certainly need to include cost effectiveness. Thank you very much.
Thank you very much, Professor Marston, for your excellent presentation. If we have any question from this presentation. Okay, so we move to next presentation. The next presentation will be provided by Professor Suwana Arumpung Faisal. Yeah, she's a professor in psychiatry, and as a psychiatrist, she has expertise in diagnosis, treatment, and prevention of mental illnesses. In addition, she introduced herself as her background is research in the field of area of substances, suicides, and schizophrenia. Her affiliation is from the Tanyaruk Hong Kong Hospital, Thailand. Thank you very much.
Thank you, Chairman. Good morning, ladies and gentlemen. It's my pleasure to present my Scale Up National International Initiative, Enhance Effective Service for People with YABA or Methamphetamine Use Disorder through Research and Practice from Thailand. Please change the slide. Okay, thank you. You will know that YABA and marijuana and kratom are most common used drug with ICE epidemic emerged since 2003, and our illicit drugs have increased since 2016, especially after COVID epidemic and the new 2021 narcotic code. In 2024, among estimate 1.7 million have methamphetamine use in 1 year, and 260,000 15% have high risk acid score. And from the Department of Mental Health, we can see that we have serious mental illness about 1,691,000 person that have mental illness, but in this group they have drug dependence about 695 and 400 patients, and they have both used the drug and psychotic patient and make the serious violent about 58,783 estimated 10% of the case that use the drug and also have serious mental illness. And in Thailand, we try to develop guidelines for treatment and rehabilitation of drug addicts according to the Narcotic Code, revised on edition 2024. And we try to look at the patient journey, that patient come to the hospital mostly is 60% voluntary, and 30% come from by officer and 10% by cost. And patient will come to the outreach center to screening with assist. And we will find that 10% have a high risk user with psychotic, with violent. And we have an indicator by over aggression scale about SRI-3. They will sent to the hospital, special hospital for treatment and for admission. And so the second one is the high risk but no violence, but only symptom agitation, about 55%. They will assess comorbidity and have admission in the provincial hospital, have a short-term treatment like a detoxification, and after that sent to intermediate care, have psychosocial interventions such as motivational interviewing and psychosocial intervention. And follow up for the case that assist is a moderate risk and my symptom of psychiatric, no violence, they will have sent to community hospital and have the brief intervention and follow up at least 1 year. And for the low risk, like occasional user, they no psychiatric symptom, they will give education and follow up in community-based treatment for substance use. And this is the care cascade from Thailand that we try to, the case have substance severity, they will send to the doctor to assess clinical and screening with the 9Q is a depression, AQ is a suicidality, and OAS is the aggression, overt aggression scale. And we use the collaborative information and physical exam, mental status exam, and psychosocial assessment. Then we give the clinical diagnosis based on ICD-10, such as intoxication or withdrawal or physical illness. And also we assess violent list too. And for the psychosocial, we assess state of change, self-efficacy, and supporting system, family function, and psychiatric disorder. And then treatment, we have acute care 1 or 2 weeks for detoxification and use psychotropic drug to reduce the symptom at that time. And after they improve symptom, they will give with intervention and physical care and family psychoeducation, and then send to the intermediate care about 1 month, give the motivational interview and psychotropic medication maintenance and family intervention and group therapy such as a matrix or CBT or systemic systemic transformation therapy and EMDR. And after intermediate care, they will send to long-term care about 3 to 4 months. And after that, discharge, follow-up 1 year, they will receive from the long-term care, they will receive the psychosocial interventions such as the therapeutic community, CBT, case manager, random urine drug screen for post-discharge follow-up, and caregiver counseling, home visit, and have a group, self-help group like Alcoholic Anonymous or Narcotic Anonymous. And also we have social rehabilitation center in the community isolation. And this is the facility that in Thailand have. We have screening center nearly 10,000, and we have drug treatment about 1,081 center, and belong to government more than private. And also we have drug rehabilitation facility about 274, and we have social rehabilitation about 5,372. And now, nowadays we have mini Tanjalak cover about 74 provinces to give the social rehabilitation and intermediate care. But however, we try to find the pharmacological treatment because they have no FDA approved for pharmacotherapy in methamphetamine. But we use the mirtazapine, we use the bupropion as an off-label because they have symptoms of depression. So we use this, but we don't have evidence base that is good enough to use as a effective medication for this one. So we know that evidence base for psychosocial intervention is a CBT and contingency management, but we still have a strategy to practice in real world that we need to find out that which one is suitable for Thai culture. And this one, initial Thai effective medication, we will study mirtazapine about 15 to 60 milligrams per day, and bupropion, compared with bupropion, 150 and 30 milligrams per day, and long-acting methylphenidate, about 54 to 180 milligrams per day for 24 weeks. Compared with treatment as usual for reduced harm effect. The outcome is the harming effect in real-world clinical practice for methamphetamine use. And we want to know the safety of this drug. And also we want to evaluate the cost effectiveness from this drug too in real-world clinical practice. So this is the research methodology that we have. It's a pragmatic non-blind four group parallel randomized controlled trial multi-center study. And setting, we have two settings. It's a Thanjarak Hankan Hospital and Thanjarak Chiang Mai Hospital. And we calculate the sample size with 4 arms. We think that we need to 440 cases, patients with age more than 18 to 65 years old, and no any limitation, no realistic inclusion exclusion criteria. So we try to recruit them all, and we use the instrument to measure the harm effect of methamphetamine with 15 instruments and follow up 9 visits. And data analysis, we use the standard for descriptive is percentage and standard deviation, mean interquartile. And then because we have repeated measure, so we use the repeated measure analysis of variance and linear mixed model. The measurement from 13 is the we have questionnaire developed by harm, look at the harm effect from literature review, and then we validate this questionnaire. And we have acid type and OAS, AQ, 9Q, amphetamine withdrawal scale, and also use the craving scale for methamphetamine, and quality of life, adverse drug reaction, and Chulalongkorn family inventory to look at that they have the family function okay or not, and have the case report form for cost, expense, and satisfaction of care questionnaire, and also lab test for the case. And this one is the protocol that we try to develop 2-year study period, and we have 21 investigators, and we receive funding from ONCB, Thai ONCB, about 12 million baht up, and we randomize into 4 arms. The problem is this is the process that we develop. One, we receive grant from ONCB on March, and we MOU with University, Chiang Mai University, Khon Kaen University, and Thanjarak Hospital. And then we obtain authorization from author for instrument and validate them. And finally, protocol and methodology and tool finish, and then we preparation research site and team. After that, we have ethical review from SELECT. SELECT is a multi-center IRB that first is belonging. So we try to receive the approval from this one, but need time a lot, maybe nearly 6 months. And we try to develop REDCap data management system to perform data record form. And we have FDA preparation to provisional study drug like a methylphenidate, but we have problem to access it because the methylphenidate in Thailand, we have quota from outside, and we compete with child psychiatrists to treat ADHD. So the drug cannot afford at the study period. So we think that we will reduce the arm from the methylphenidate arm first. If not, it will delay until next year. And then we will give the amendment from EC again. And we think that we can start recruitment about September this year. And this one make us we try to do pragmatic non-blind for group parallel on this protocol that we talk with UNODC scale up many times, and then some opinion give us, and now we undergoing for IRB approval, but the delay is delayed 6 months delay in plan schedule, and maybe protocol amendment will be discussed methylphenidate arm. And furthermore, we still interested in efficacy trial with novel medications such as listed, like Professor John Madden. And also we interesting in cannabidiol, and combination between mirtazapine and methylphenidate and bupropion with naltrexone also. But this is the next step for us. Thank you very much for your attention.
Thank you very much for this very helpful and informative presentation. For the next speaker, Ms. Anya Buse will present on stimulant use and stimulant use disorder updates from WHO. She joined the WHO in 2025 as a unit head of drugs, alcohol, and addictive behavior. With a background in psychology and public health. Before WHO, she worked about 20 years with UNODC. She coordinated the agency's global program on treatment of drug use disorder, including the UNODC WHO program on drug dependence treatment and care, and other large-scale implementation and technical assistance projects reaching more than 50 countries in all regions. Thank you very much, and the floor is yours.
Thank you so much, Dr. Ali Reza. And what I want to present to you is what a lot has been mentioned already throughout the conference and also here on podium, really this interagency initiative called Scale Up, Scalable Interventions for the Treatment and Care of Stimulant Use Disorders, which is now being supported by the World Health Organization, UNODC, and also the European Drug Agency. And, I mean, really relies on the work of researchers who we formed an informal network with, like the ones we have here on stage, but also many additional researchers who work with us by now for a few years from North America, South America, Asian sites, Australian sites. We've recently included kind of South Africa. So it's really a network of researchers that came together, most of them currently involved in clinical studies around treatment of stimulant dependence, and focus has been a lot the discussions on pharmacological treatment, but not only, I mean. And just wanted to set the scene a bit, why as international organizations we also got involved in this, and we're trying to provide with the Scale Up initiative a platform really to maybe have some of these discussions as mentioned here around common outcomes, common measures, commonalities, partnerships, as Professor Farrell had mentioned before. And so these are data from the World Drug Report, right? So just at international level, the last World Drug Report estimated around 31 million people using amphetamines, an additional 25 million people using cocaines. And this thing that really worries us is that the treatment gap is vast, right? So worldwide, on average, only 8% of people with drug dependence or in need of treatment have access to services. So, and that's one of the major problems, and people with stimulant use disorders likely find themselves to a good extent in this percentage where there is no access to any form of treatment. And then in this 8% that have access to treatment, of course, the quality of such services is the next question. And as you can see, the ratio is always worse for women than for men. And this is in general, right? And here, this slide also from World Drug Report kind of shows the number of people using, in this case, I've highlighted amphetamines or their prevalence. So for the Southeast Asian region, you see that this is kind of blue. Sorry, I've only moved here and not there. That is this blue dot, right? So that really shows that the number of people using amphetamines is highest here in the region. In terms of prevalence, so in relation to the population number, there are other regions that have even higher prevalences of amphetamine use than Asia, but still good to see both in numbers and in prevalence rates. And then this slide kind of gives an idea between the access to treatment. And here you can see that in Asia, and I think my colleague Zinko had showed this slide before in another session, right? So overall, access to treatment is rather low, also in comparison to other regions of the world, and is especially low in this region, again, for women. For those that have access to treatment, then in the broader Asian region, amphetamines are among it's a substance for which the most people are seeking treatment, but let's say the most internationally controlled substance, right? So this is excluding alcohol. And then this is what has been mentioned here a lot throughout the conference also, of course, the negative health and social consequences associated with non-medical stimulant use. So there was a lot of concern around stimulant-induced psychosis here, but maybe just to mention, of course, also infectious diseases, social marginalization or incarceration, kind of criminal justice contacts we had heard about. So, and these are rather old, I have to say, but WHO estimates on deaths attributable to drug use, where usually we're looking at the opioid numbers, but here are also numbers, for example, for amphetamine and cocaine, where the majority here are driven by hepatitis or road traffic accidents, and as a second in the amphetamine bracket. And just to say that we're currently updating these numbers, and hopefully by the end of the year, early next year, we'll have new data available. The other reason beyond the epidemiology and negative health and social consequences associated with stimulant use and stimulant use disorders, and this that we heard, and I have to say this is more anecdotally from countries we worked with, how much stimulant use disorder responses even are associated with human rights considerations, right? So that in countries where, for example, stimulant use and opioid use is existing and methadone maintenance services are available, so for people with primarily opioid use disorders, often more services are available in the community, whereas for people with primarily stimulant use disorders, often more punitive approaches like detention or involuntary treatment are a response. And also that kind of, in addition to epidemiology and the health consequences, really made us think that it is going to be important to look at an initiative to address that. In 2023, so as you heard, this is before I joined WHO, the colleagues at WHO for the update of the WHO MHGAP guidelines, which are guidelines for non-specialized health services. I have to say, looked at the evidence for psychostimulant interventions. And they found, and I think this is similar to what Professor Farrell had presented before, that there is kind of, or that recommendations can be made around offering screening and brief interventions, or, for example, psychosocial interventions like cognitive behavioral therapy and contingency management that you have heard in this plenary. But at that time, in 2023, and again for non-specialized services, it was also said that a number of medications, such as dexamphetamine, methylphenidate, modafinil, would not be recommended for non-specialized services, right? So nevertheless, there was a consideration for future directions, right? So what is needed to maybe close this treatment gap and also find better evidence and develop evidence also for pharmacological treatment. So one of the considerations was, of course, that while most of the studies are being conducted in high-income countries, it's also important to find studies that are being conducted in low and middle-income countries. And we're very pleased to see that this is now starting to happen, including in some of the sites we have in our informal network around scale-up. And if we really want to talk about scale-up, of course, in the future, we will also have to see what works in addition to specialized settings, right? So the top of this pyramid that Nadine had showed, what other interventions can also work in non-specialized settings. And I guess, again, in Nadine's presentation, there were a few recommendations or suggestions also for this. And cost effectiveness as an additional factor is also mentioned already by the researchers here with us on the panel. So, and then around in 2023, we really started to form this very informal network, mainly working through online meetings of researchers currently working on clinical trials for stimulant dependence, as I said. And then in 2024, there was first kind of a launch by UNODC of this Scale-Up initiative. And then in 2025, also WHO and the European Drug Agency officially joined the Scale-Up initiative, which is really there to provide a platform and enhance partnerships among researchers, but also countries, civil society concerned kind of with the issue of closing the gap, let's say, of finding better services for people using stimulants and with stimulant use disorders. And so and the goal is on one side to see how we can better implement existing evidence-based, mainly psychosocial approaches, such as contingency management, where the challenges with it have been mentioned already, right? So it has strong research evidence, but there are a lot of challenges actually translating it to, let's say, standard community services, how that can be done. And Dr. Ali Reza, who's here on stage with us, is actually also looking into that for a very difficult setting, like in Afghanistan, for example, and hope to learn a lot from that as well. And on the other side, Scale-Up is really there, or had the idea to promote research on pharmacological treatment options like everybody here on stage is currently leading. So what was our vision or our dream is to do this multi-country study. And we felt encouraged because, you know, there used to be many years ago, at least on feasibility, multi-country study led by WHO on methadone. We had recently done WHO and UNODC, also a multi-country study on overdose. This one would obviously be more complicated because A, we have no approved medication, right? And therefore there are additional challenges involved with a multi-country study. But we hope kind of, you know, coming together and that this could become a reality. So, and, you know, there would be different phases. We would need to take our time to see which sites are joining, have situation assessments, develop common protocols, adapt those protocols, have a lot of discussions on what came up here around outcome measures, around what medications, you know, a lot of factors that still would need to be figured out, but then hopefully kind of do joint evaluation and data analysis. So, but in principle, also to say that Scale-Up also tries to provide a platform to come together, generate information, also support in addition to research capacity building, really this mutual support and exchange, and therefore, in a way, will also contribute to the 2030, which is very soon, Sustainable Development Goal achievement around strengthening prevention and treatment and increasing coverage of treatment also for this group. So And this is just to highlight and again to thank Thailand for taking the leadership in the resolution this year at the Commission on Narcotic Drugs together with Norway. And in this resolution, the Scale Up Initiative has been particularly mentioned in the text of the resolution. So we feel very comfortable that this is not only an idea from research or from international organization secretariats, but it's really backed up by the member states of this world to say, yes, I mean, we think there is a need, and yes, we please want to see more research and work on this. So currently with the Scale Up Initiative, I mean, as said, we have this informal network of researchers. The initiative has been launched. We do have the resolution. And in fora like here, it will be a good moment to regionalize further the Scale Up Initiative. Hopefully, you know, your researchers, practitioners, policymakers from different countries in Asia to come together, also with the European Drug Agency that has joined. There's already going to be a regionalization of it in the European Union. And I will just mention in the next moment what also through a WHO process in terms of developing target product profiles, maybe we can help in addition to this, what we still hope and want to do, the exploration of an option for a multi-country study. So this is kind of the plan at this moment. Maybe I would always say, in addition to exchange capacity building, and maybe this I just want to end with. So WHO has a standard process of developing target product profiles. And I think that goes a bit in the direction what Professor Farrell was mentioning before, right? So when COVID hit, WHO developed target product profiles, and very quickly kind of there was an international direction to say, this is a kind of vaccine in that case we would need to see. And it gave guidance to both industry, to regulatory agencies, and so on, what to develop. So in that sense, we're hoping to also develop these target product profiles for stimulant dependence treatment, and mainly likely for medications. I need to say that target product profiles have never been developed before for anything in the substance use or substance dependence area. So it would be a novelty, and it would also be an advocacy message, because just by developing a target product profile, WHO is saying that this is an urgent public health need, right, that needs attention. And this is really then a formalized process in which, under the leadership of WHO, experts, scientists, regulatory agencies, but also pharmaceutical companies, people with lived experience, can come together and have an impact in really developing further this, what has been mentioned by both John Marsden and Professor Farrell, kind of this Steve Shoptaw kind of guidance on what do we need to see if there would be a medication through this, you know, additional structured process with input from many stakeholders. So that's where I want to end. And if you want to join in one way or the other the Scale Up Initiative, especially if you're a researcher doing clinical studies in this field, or if you're a funder and think that you can support this work, I mean, definitely reach out to any of us. And we hope to come back to you maybe in a few years or in 2 years when there is a next conference, already with some of the results of work that have either happened in coordination or jointly through coordinated work. Thank you so much, and thanks everybody on plenary and who else is in the clinical trial or in this informal network that we have for the constant work, because we really couldn't do without all of you. So thanks for that.
Thank you very much. We need to be cognizant of time. Thank you for your attention to this panel. I want to seek your permission for and also the esteemed panel members to stay with us for if you have any question or comments on the presentation. As you can see, there are lots of very interesting research is ongoing, and we are eagerly waiting to receive the results of this very interesting and high quality, well-designed research studies, both internationally in UK and in Thailand, so and in Australia. So and it is also a great platform that provide research assistance and technical assistance for member states for designing high quality clinical studies. So if colleagues wants to contribute or make a comment, so please.
Okay. On behalf of the organizing committee, I would like to thank for all the panelists for joining us for this morning and for giving very useful insight about your work, your research to contribute for our conference. And give me a few minutes to take group photos of the panelists. Yes, thank you. Okay. And before we have a morning break, let me take some few minutes for organizing some best paper award for the poster presentation. So please. May I invite the panelists from the stage so that the staff will clear the table for the best paper presentation award, please. Okay, may I invite Ms. Aripak Ngenbamrung, the Deputy Secretary General of the Office of the Narcotic Council Board, on stage to present the certificate for the researcher, please. Okay, for the first paper. For the first paper is by Hae-Sun Kim under the topic of the development and dissemination of rehabilitation support program for psychotropic drug users in Korea. Please. Thank you. Thank you. And the next is Griang Kai Phung Chua under the topic of the estimation of population related with substance abuse Thailand, National Household Survey 2024 Bangkok. And please let me take a few minutes for the group photo. Okay, and for the next paper is from An Ngok Chan under the topic of the association between adverse childhood experiences and methamphetamine use patterns, finding from a secondary analysis of the Thai MICE questionnaire dataset, and also the work from the Marcier Hamsedale under the topic of the development of a comprehensive psychosocial guide for treatment of people with stimulant use disorder in Iran. Okay, ladies and gentlemen, we will have a morning coffee break. Let's say from now, which will end from now until 11:10. And I would like to tell you to take your belongings with you from the conference room, because we have to take some time for arrange the room into the breakout rooms. So the breakout for the breakout session will start from 11:10 and will end around 12:30. And after that, we will have a lunch break at the market on the 5th floor, and you will get a lunch coupon from our staff in front of the breakout room. Yes. Okay. Let's have a morning break.